So my name is Michelle Brazis, and I'm the Associate Director of Adaptive Oncology. Together with my colleagues Shola and Jay from Clinical Translation and Therapeutic Innovation, respectively, we host OICR Mondays, a discussion series highlighting research ideas and challenges along the cancer continuum. The discussion series aims to gather the cancer research community to discuss contemporary issues in the field of cancer research, identify opportunities for collaboration, and brainstorm on innovative cross-disciplinary approaches that may lead to improved outcomes for cancer patients. So the format of today's session is a little bit different than a traditional seminar series. We'll have 3 short presentations from our speakers, followed by a 30-minute discussion. So please save your questions for the discussion period. You can put them in the Q&A chat box or the chat itself. And this is a webinar, but you do have the opportunity to raise your hand and I can unmute individuals and you are free to speak with the speakers. So now I would like to introduce our moderator for today, Dr. Raymond Kim, who will guide us through the session on unmet clinical needs in hereditary cancer. Dr. Raymond Kim received his MD PhD from the University of Toronto with Dr. Tak Mak in medical biophysics. He then completed a residency in internal medicine, followed by a fellowship in medical genetics at the Hospital for Sick Children. His clinical interests lie in the transition of care, complex multidisciplinary care, and adult hereditary disorders. His research incorporates novel genomic technologies in clinical care, including whole genome sequencing and circulating DNA. He's medical director of cancer early detection and the Balwani Familial Cancer Clinic at Princess Margaret Cancer Centre. He is also the director of the Ontario Hereditary Cancer Research Network at OICR and provincial head of the genetics program at the Ontario Health. So at this point, I will turn it over to you, Ray, for a short introduction on the topic.
So thank you all for inviting me and on behalf of the speakers to this important OICR Mondays. My name is Raymond Kim, and I'll be providing a brief overview on what hereditary cancer is. Cancer genetics is actually becoming more and more complicated, which interplay between your inherited genetic material, which we know as the germline, and the somatic genetic events, which are seen exclusively in tumor cells. And in the germline where I sit, we look at families that have hereditary cancer. The inherited genetic material encodes our drug metabolism genes and our HLA typing for bone marrow transplant. And a lot of the advances in cancer genetics have been looking at tumor genetic changes, which are involved in treating patients in terms of cancer neoantigens, mutational processes, driver mutations, tumor heterogeneity, and a lot of these advances oncologists use to take care of our cancer patients. Now, the genomic analysis of cancer has become extremely complicated, mainly driven by the sensitive genetic technologies. Now, we can look at the tumor, which has treatment implications, but also tumor heterogeneity plays a large role in how cancer progresses. And then the blood is a unique entity where you have white blood cells, which we use to represent the inherited genetic material. We also have cell-free DNA, which looks at little bits of DNA that are released in the blood that Julia and Erik will talk about. And then we also have other genetic events known as clonal hematopoiesis that are specific genetic events that occur inside white blood cells alone. Now, sometimes because patients have leukemia, we have to use skin fibroblasts to look at normal DNA, where blood DNA isn't representative of the inherited genetic material. So all of these tissues play an important role in understanding the genomic analysis of all cancer. Now, tumor profiling results in personalized medicine, where back in the day we were interested in certain targetable genetic mutations. But as genetics moved into the field of genomics, where we were studying more and more genes as opposed to a few genes at the same time, the intersection between precision cancer medicine and hereditary cancer became more prominent. A lot of it is because of up to 10% of cancers have an inherited reason for their cancer. And a little bit about hereditary cancer. The famous person is Angelina Jolie. So Angelina has a BRCA1 pathogenic variant. She was born with this genetic change. She has a strong family history of breast and ovarian cancer, and she is known as what we call a previvor, otherwise healthy. And then most people undergo intensive surveillance and then invariably become a cancer patient, get cancer treatment that's often personalized to that germline pathogenic variant, and then become a cancer survivor, hopefully. And then this cycle continues because that genetic event is in their whole body. Now, this provides us a unique opportunity to understand the biology of cancer because these patients are so valuable, and this potentially can inform care for all cancer patients. A lot of precision cancer therapies were discovered on hereditary cancer patients. PARP inhibitors were discovered on BRCA1 carriers and BRCA2 carriers over 10 years ago. Similarly, denosumab is thought to be effective in breast cancer for BRCA1 and BRCA2. Immunotherapy for Lynch syndrome, which is mismatch repair deficiency. And recently, belzutifan is a HIF-2 alpha inhibitor that is being used in patients who have familial forms of kidney cancer and pheochromocytoma, known as von Hippel-Lindau syndrome, that Karen Gomez will talk about later. Now, the ultimate goal for us is to obviously try to prevent cancer in these patients. There are advances in cancer vaccines. Now, we can't change a person's inherited DNA, but we can potentially use vaccines to prevent cancer from progressing in these patients who have a first hit that is acquired in their blood. Now, how this actually works has yet to be fully elucidated, but we do think that at least in mismatch repair, where patients who have Lynch syndrome have a lot of different genetic epitopes that are being presented on their cancer cells and respond well to immunotherapy, that this is a window of opportunity that will allow us to prevent cancer in these patients, to design a cancer vaccine that presents these epitopes rather early to prime the immune system to prevent those cancer cells from progressing. Now, I hope I was able to articulate the importance of hereditary cancer patients, and we at the OICR and Adaptive Oncology have launched the Ontario Hereditary Cancer Research Network, or the OHCRN, which is led by our genetic counselor and program manager, Lauren Hughes. And this registry plans to identify all the carriers in Ontario to allow this centralization and harmonization of data to inform patients and cancer genetics and genomics researchers on potential advances and enroll patients in clinical trials, early cancer detection, and all under the auspices of data collection under a standardized manner. And there's a real opportunity in Ontario because we used to send a lot of genetic testing out of the province, and now 9 labs in Ontario test for hereditary cancer under a standardized gene set. But there's still opportunities for us to collect this data under the OHCRN. So with that, I will stop sharing and introduce our first speaker, Julia. Now, we'll give Julia a second to share her screen. Now, Julia is a genetic counselor at the Princess Margaret Cancer Center and program manager of the CHARM Consortium, which is cell-free DNA in hereditary and high-risk malignancies. Now, CHARM is a pan-Canadian research initiative with the goal of revolutionizing the management of patients who have hereditary cancer syndrome through the development of a blood test for early cancer detection. Now, Julia has a degree in molecular genetics, a master's degree in genetic counseling, both from the University of Toronto, and we're delighted for her to be here. Now, Julia?
Okay, thanks, Raymond, and thank you, OICR, for having me. So yes, as Raymond mentioned, I'm going to chat a bit about CHARM, our CHARM research initiative, and I really want to focus on what we've called CHARM2, which is a new trial that will be starting up this year. So before I jump into the details about CHARM and the trial, I want to briefly go over the concept of cell-free DNA testing. What is cell-free DNA? It's key to CHARM. Some of you are probably already quite familiar with what cell-free DNA is, but just to make sure everyone's on the same page, especially for any patients who might be joining now or watching later. So most of our DNA is located inside of our cells. But if you look at our blood, there will be these small fragments, pieces of DNA that are free floating. So they're not encapsulated inside of a cell. And this is why they are called cell-free DNA. It's totally normal, completely normal for us to all have this cell-free DNA in our circulation. Most of it comes from normal, healthy cells as they age and die and undergo apoptosis. These small pieces of DNA are going to get released into the bloodstream. Now, if someone has a tumor, small cell-free DNA pieces can also get released from tumor cells into the blood. And the cell-free DNA that comes from tumor cells will look a little bit different than the cell-free DNA coming from healthy cells. So tumor cell-free DNA will have certain markers that distinguish it. I've indicated that with these little red dots in my figure here. And what this allows us to do is take a blood sample from someone, extract or pull out all of that cell-free DNA, and using genetic technologies, we can analyze it to see if all the cell-free DNA looks like it's coming from normal healthy cells, or if there's any cell-free DNA that has tumor markers, which would make us suspicious of cancer. So ultimately, cell-free DNA can be used, testing can be used as a tool for early cancer detection. So how might this tool benefit individuals who have a hereditary cancer syndrome, which Raymond already introduced what exactly that is. Like Raymond mentioned, individuals with hereditary cancer syndromes, of which there are many types, are at high risk of developing several different cancers over their lifetime. And as a result, they enroll in fairly intensive clinical screening programs to monitor their risks for the different cancers. So patients may have different imaging tests done every year, blood work done every year, to monitor for cancer. There are pretty big gaps and challenges with current screening programs for patients. So a couple examples, not all cancers have good screening tools available. Some cancers are difficult to screen for and detect early, so they're either detected late or they're missed. Many tools are screening tools are cancer or organ specific. So for example, mammogram is specific for breast cancer. But since patients with hereditary cancer syndromes are at risk for several different cancers, it can mean multiple separate tests, which can be fairly burdensome. And then not all screening tools are readily available and accessible. So depending on the screening tool, it may only be available in a specialized center in a major city, which means that patients might have to travel pretty significant distances to get their regular screening done, which again, it's pretty burdensome. And so accessibility is a real problem. And cell-free DNA really is a promising tool to address some of these gaps and challenges. So there's a pretty big body of work that has shown cell-free DNA testing can detect many different cancers. Also, of course, the sequencing technology to analyze the cell-free DNA might only be available in certain specialized centers, but the blood draw itself is minimally invasive. It's accessible. Patients can get their blood drawn close to home, and that blood can be shipped to the specialized center, so reducing some of that burden. So this brings me to CHARM, which stands for cell-free DNA in hereditary and high-risk malignancies. So this was a research initiative started in 2018, and it brings together scientists and clinicians from several institutions across Canada. And I've put at the top of the screen here a map of which institutions are involved in CHARM. And as Raymond mentioned, really the goal of CHARM is to develop a cell-free DNA-based blood test for early cancer detection in patients with hereditary cancer syndromes. So to date, CHARM has been retrospective or correlative only. So what we've done for the past 4 or 5 years, collect blood samples from patients with a variety of different hereditary cancer syndromes. Blood is collected every 6 to 12 months, give or take. And it's collected in Streck tubes. So these are specialized tubes that stabilize cell-free DNA at room temperature, meaning there's a bit more wiggle room between when the blood is collected and when it needs to be processed. So patients can give blood for the study in community next to their home. They don't have to come to the hospital. The blood is then processed into its components and it's stored in our biobank. And after enough blood samples are collected for a specific cancer syndrome, and especially after we have enough longitudinal samples, so serial blood samples collected for patients, We are going to then pull the samples, retrieve them from biobank, we sequence them, and we correlate the results with the clinical histories and the cancer screening patients have done. So, for example, if a patient, we do cell-free DNA sequencing and it looks like in one of the blood samples, there might be markers for tumor. We then will go look into a patient's clinical record and see if at the time their blood was collected, did that patient have a diagnosis of cancer or was there suspicion of cancer? Or if not at the time of blood collection, X number of months later, did the patient develop cancer? And so the goal of CHARM to date, which I tend to just call CHARM1, has been test development. So trying to figure out which sequencing techniques and what kind of subsequent analysis is best at finding the tumor markers in the blood. And I'm not going to go into the details of the sequencing analysis. That's something that Erik's going to go over. And he'll chat a little bit about those details. But I also have put on the screen here a paper that was recently published about all the work done in Li-Fraumeni syndrome. So one specific hereditary cancer syndrome. So if anyone is interested, can check it out. What I really want to focus for the rest of my time is on our new trial that will be starting up this year, which essentially puts the experimental cell-free DNA blood test into practice. So CHARM1, like I mentioned, everything was correlational. We did not return any results to participants. We did not follow up on any results. In CHARM2, we will now return the results of cell-free DNA testing to patients and their managing physicians for clinical follow-up. And so we ultimately want to know, how does cell-free DNA testing compare to existing cancer screening protocols? And this trial was made possible by a very generous grant from that we received from the Canadian Cancer Society, and Drs. Trevor Pugh and Raymond Kim are the clinical and academic leads for this trial. So similarly as for CHARM1, we hope to enroll patients across Canada at our various CHARM sites, and we're going to enroll 1,000 patients who have one of the 4 different hereditary cancer syndromes I've listed on the screen here. So hereditary breast and ovarian cancer, your BRCA1/2 carriers, Lynch syndrome, Li-Fraumeni syndrome, and neurofibromatosis type 1. And I've just also listed on the screen here the cancers that these 4 cohorts are higher risk for, really just to give you an idea of the diversity of cancers, even within a single cohort. And again, thinking about the challenges of having to screen for all these cancer types. So once we enroll 1,000 patients, patients will be randomized into one of 2 groups. There's the experimental group and the control group. Both groups are going to continue to receive their standard of care cancer screening that they were receiving prior to enrollment in the study. So this includes various imaging, blood work, so on. Patients in the experimental group are going to have CHARM research blood collected 3 times a year, so every 4 months for 4 years. And every blood sample will be processed, cell-free DNA will be sequenced and analyzed, and the 2 tests that we plan to do on the cell-free DNA, at least at the start of the trial, are going to be a targeted panel and a low-pass genome. And Erik will touch on what this is and how cell-free DNA is looked at with these 2 tests. And then a clinical report will be generated and returned to patients. Now, most reports results we expect to be negative, so there won't be any follow-up needed. The patients will just going to continue with their standard of care screening and in 4 months' time get their next CHARM research blood draw. If a result is positive, then the study doctor at the site where the patient was recruited, so at UHN, that would be Raymond Kim, will order follow-up testing to confirm if cancer is present or not. And in a couple of slides, I'm going to go into what exactly, or an example of what that follow-up testing might look like. For participants who are randomized into the control group, they have the option to, over the course of the trial, donate samples to continue the growth of our CHARM biobank. And these samples would be used for future research. So for example, if a new sequencing technology becomes available, then we would have samples already to kind of hit the ground running with that research. But for the purpose of this trial, the control group are continuing to have their standard of care screening, and our CHARM team is just collecting the results of that screening and using that as a baseline or as a control. So we have these 2 groups, both of which are getting standard of care screening, but one group, the experimental group, is also getting cell-free DNA screening 3 times a year. And between these two groups, we want to compare what types of cancers are detected, how early are those cancers detected, so the stage, when does the patient access treatment, how long are they on treatment, and generally their outcome. And ultimately, we want to understand how cell-free DNA testing compares to current standard of care screening protocols. Is it better? Is it worse? Is it the same? Just a couple quick items that I wanted to point out about the logistics and workflow. For the trial, since patients, and in particular patients who are randomly assigned to the experimental group, they'll be providing blood 3 times a year. And we don't want patients having to come on site to the hospital 3 times a year, especially if they live far away. We don't want that to be a barrier to enrollment. So patients will, throughout the trial, have the option to give blood at their local community lab. So Life Labs or DynaCare that is nearby. And then that blood will be shipped to us. Another thing I want to point out is about clinical data collection. So accurate clinical data collection over the course of the trial for the patients is really important. Of course, this is how we're going to ultimately determine the accuracy of the blood test by comparing the results to clinical screening. So a couple of really great software developers in Trevor's lab have developed a nice secure web application called Oncographer that's going to be accessible to research staff across all sites, where they can deposit the clinical data for all the patients enrolled. I also want to give a really big thank you and a shout out to the tissue portal and genomics team at OICR, who will be involved in everything from sample receipt and banking all the way to sequencing and report generation. And both groups have been super helpful in helping us sort out some of the logistics of sample flow up until this point. We definitely could not do the trial without you, so I want to give a big thank you. And the last thing I want to point out is our goal around turnaround time. So once the sample is collected, it'll probably be a couple days before it gets to OICR. And then once the sample makes it to OICR, we're hoping that the turnaround time between sample receipt and report generation will be about 45 days. So I mentioned earlier that if a result comes back as positive, we'll need to do clinical follow-up to confirm if cancer is present or not. So the initial test that we will run, that targeted panel and that low-pass genome, is not going to give a tissue-specific result. It is a general, or it is generally telling us that a cancer signal has been detected, but we don't know what tissue it might be originating from. So the study doctor will bring the patient in and will essentially go looking for the cancer. The tricky thing is that for each of the 4 different cancer syndromes enrolled into this trial, patients are at risk for several different cancers. So it's not just a single clinical follow-up test that would need to be done. It ends up being a bit more complicated. And so clinicians have worked, or clinicians who follow these patient populations have worked closely over the past year to come up with clinical follow-up workflows for each of the 4 different syndromes enrolled in the trial. And they really tried to balance the burden that the follow-up investigations can put on patients, comprehensiveness of the follow-up investigations, and also cost, because these investigations are triggered by a research result. They're not funded by OHIP. It's research funding that has to cover the cost of these investigations. And so the order of the investigations will depend on the cancers a particular participant is at highest risk for to lowest risk for. So for example, what I'm showing on the slide here would be a patient who is a carrier of a BRCA1 or 2 variant, and they will be at highest risk for breast cancer, so that's where we would start. But we also have to take into account prior medical history. So whether the patient has a history of cancer, whether the patient has had any prophylactic or risk-reducing surgery to reduce their cancer risk. So for example, if a patient who has a BRCA1 or 2 variant has had a mastectomy, so has had their breast tissue removed to lower their breast cancer risk, breast cancer is no longer going to be the cancer they are highest risk for. So we wouldn't do that first in the workflow. That would be put later down. So all this has led to the creation of about 20 or so different workflows that take into account the various factors and will be used as guides by the study doctors when they're ordering the follow-up investigations for the cell-free DNA results. Oh, and one thing I wanted to mention on this slide here also is I put a star next to the cancer types that currently don't have good screening tools available, so ovarian and pancreatic cancer. Again, just highlighting really the need for better screening tools. The very last thing I wanted to mention briefly about the trial is the big qualitative component, which I would say is just as important. We really want to hear from patients about their perceptions and experiences with cell-free DNA testing. So we've developed questionnaires that measure a variety of different emotional outcomes like anxiety, depression, risk perception, empowerment. And these questionnaires will be given to participants over the course of the trial, along with interviews for substantive participants. And so we want to know, for example, how is cell-free DNA testing 3 times a year impacting emotional outcomes like anxiety? So previous studies have shown that when screening intervals increase, so the longer you go between your cancer screenings, anxiety and fear can increase. So it's possible that cell-free DNA testing being done more frequently maybe provides some reassurance between and reduces that anxiety and fear between those clinical screenings. But on the flip side, we also know, and studies have shown, that with each screening test done, there is a general spike in anxiety. Of course, understandably so. Around the time of screening, when patients are leading up to the screening, at the time, while they're waiting for results, there's that spike in anxiety. So we want to know, is having testing 3 times a year, is it going to cause too much anxiety, too much cancer-related worry, or is that not enough? So finding that balance is going to be really important. And it will be really interesting to see how perceptions might change over the course of the 4-year trial. So maybe in year 1, participants are thrilled to have screening done 3 times a year, but by year 4, they're finding it now a little bit too burdensome. So that will be interesting to see. The last slide I'll end off with is just a summary recap of the plan for the trial. So unfortunately, we don't have any preliminary data to show. We have not started the trial yet. We're hoping to begin enrollment within the next few months. And I'm certainly happy to come back to one of these meetings and present updates once we have data to show. I have also included a link to our website, which will have updates about the trial as well. So if of interest, you can kind of follow up there. And that is all I have to present. Thank you very much for listening. And I think questions will be at the very end. So I'm happy to take any questions then.
Thank you, Julia. So we're going to move on to Erik, who is a master's student in the lab of Dr. Trevor Pugh. And he's going to present a little bit of the work that he is doing for early detection of hereditary cancer through cell-free DNA analysis that Julia had alluded to, and really the scientific work that we are trying to bring back to these patients. So take it away, Erik.
Yeah, so my name is Erik Ensminger. I'm a current master's student in Trevor Pugh's lab at the University of Toronto. My research is focused on early detection of hereditary cancer through liquid or plasma liquid biopsy analysis. And in this project, I apply various bioinformatic tools and computational approaches for the early detection of hereditary cancer or cancer diagnosis. So just so in the next 15 minutes, I'm just going to give a typical workflow overview in liquid biopsy analysis. I'll go over the different types of sequencing techniques that we are currently using. And then I'll go into some of the analysis for example, targeted sequence panel that we are using for variant calling, copy number alteration that we look through plasma whole genome sequencing, and then also a really novel and upcoming field in fragmentomics. And then I'll just give a brief overview again. So this is kind of a typical workflow, and kind of Julia introduced this, but we have patients with hereditary cancer syndrome. They get a blood draw, and we are interested in kind of 2 of the layers, the plasma and the buffy, which contain cell-free DNA fragments. These have to be then extracted through a rigorous wet lab protocol, and then they can be sequenced. Currently, we're focused on targeted sequencing and 30x whole genome sequencing. And then after the cell-free DNA fragments are analyzed, we can align them to a human reference genome and can do various computational approaches such as fragmentomics, which looks at kind of the fragment features to There's fragments, which looks at fragment features to kind of find these genomic patterns or signatures for these specific cancers. We can also do very typical variant calling, which looks at mutations in the genome, and then also copy number analysis, which looks at the amplification or deletions of various regions of the genome. So here's just an overview of the two sequencing types that we're focused on, as I previously said. So targeted gene panel sequencing really focuses on only a subset of genes in the genome. In CHARM's case, we look for BRCA1 and 2 for HBOC, but also we look at TP53 and the Lynch syndrome genes. Now, the benefit of having targeted gene panel sequencing is that we really can, since we're only looking at a subset of the genome, we can have really high depth sequencing done and have or find rare variants in the genome and be confident that these actually exist and especially also in plasma. And then on the other hand, we have plasma whole genome sequencing, which doesn't focus on a particular gene, but focuses or looks at the whole genome. And since we are focused on the whole genome, currently the read depth isn't as much. We currently are using 1x sequencing depth and are going up to 30x whole genome sequencing. Now, the benefit of this is that we can not only look at, for example, genes of interest, BRCA1 or 2, but we can also look at other gene mutations or patterns in the genome, which, for example, fragmentomics, we can apply to, and various other things. So here's just driving home the point of the differences between the panel and the captured whole, or the information that we can capture through whole genome sequencing. So the panel really only focuses on that one. I'm not sure if you can see my here. You can kind of see that since we are focused only on a subset of the genome, we may actually miss these rare genetic mutations that exist somewhere else in the genome that might provide us information on the cancer. However, when we use whole genome sequencing, since we have this wider bandwidth, we can look at and find these other mutations that might not be in these hotspot oncogenic genes, but can give us sort of inference of the state of the sample. And here's just an oncoplot, which basically gives you the mutational landscape of samples and looks at the mutations that exist. So this oncoplot was generated through targeted sequencing, where we looked at not only the germline mutations of hereditary breast and ovarian cancer patients, but also really that second hit, and we're trying to look for the somatic mutations. So for example, here you can see all these patients. They each one have that typical germline mutation, which we expect and are actually clinically validated. And but then you can also see that, for example, here we have patients, or this patient has a somatic missense mutation in the BRCA1 gene, but also has PMS2 missense mutation and EpCAM mutation. And so, yeah, you can see here trends that all of these patients have or some patients we were able to kind of see that somatic mutation, which gives us this confidence that, or some idea or reasoning why they have this cancer status. And here's just kind of a more visual overview of what we're actually seeing for a missense mutation. For example, here we have a patient of the read tracks, and we can see here in the reference genome, this location in the genome has a G, but through a mutation, a lot of these reads actually have this was a missense mutation and it turned into a T. And this just kind of more broader overview, and you can really see that a lot of these reads have this mutation, and this gives us this high VAF or confidence in that this mutation exists in this patient for this or a second hit. And here, just this is an example of the same region in a different patient, but this sample does not have this missense mutation. We saw that we can use variant calling from target sequencing data to identify not only germline mutations, but also these somatic mutations in these specific oncogenic genes of interest, especially in hereditary cancer syndrome. But we have, for example, patients that are clinically validated through standard of care measures that have cancer, but in our target sequencing from plasma samples, these patients, we can't find any obvious mutations that would kind of infer their cancer positive status. Or we have, for example, these cancer negative survivor patients, which, since our goal is early detection, we really can't see any mutation, and we're questioning, okay, how do we or what other methods can we use to see their cancer or infer their cancer status as early as possible? So really going back to what I was kind of trying to explain is that the goal here is to use plasma whole genome sequencing because we have the wider bandwidth and we can look at other patterns other than just these hotspots to infer cancer status. So here's just an example of 5 hereditary breast and ovarian cancer patients where we had the tumor tissue sampled and also the plasma whole genome sequenced. So what we did, we had a mutation list from the tumor tissue, and we tried to find these mutations also in the matched plasma whole genome sample. So here, for example, when patients had a matched mutation list, we could really find a lot of these mutations from the tumor, also in the plasma whole genome. And this is a lot more than what we could find in, for example, from target sequencing, since it's only really focused on these specific regions. And here, since plasma whole genome looks at the whole genome, we can look at these genomic trends. So here's an example of a tool that we use to analyze the genome called iCore-CNA, which looks at the copy number alteration. So, and it also can infer the tumor fraction through various mathematical modeling, which looks at the content of cell-free DNA that is derived from tumor tissue versus the cell-free DNA that is derived from normal cells. So here, for example, when we look at the copy number alteration, which looks at certain genomic regions that are up regulated or amplified or down or deletion, we can see here at time point 1 for this patient, they're clinically negative, and there's no obvious copy number alteration that we can identify. However, at time point 2, we can already see that copy number alteration, or there is a change in copy number alteration. For example, here we have an amplification of in certain genomic bins. And from the iCore-CNA tool, the tumor fraction is also increased. So we're seeing some cell-free DNA that is actually derived from a tumor tissue. And at time point 3, the samples actually was clinically positive. And we can then see, for example, in the copy number alteration, it is also changed. And also we have a bit of an increase in the tumor fraction as well. So obviously this is only one kind of tool or one application that we can use to infer the tumor fraction or tumor content in a sample, but it is an important preliminary step in order to kind of see the potential in plasma whole genome sequencing. And now really what is, I think, really interesting is this kind of new developing field in cell-free DNA is this fragmentomics, which leverages these unique fragmentation patterns to detect the cell-associated signatures. So in healthy cells, for example, cell-free DNA fragments are typically 167 base pairs, which corresponds to the DNA that wraps around one or nucleosomes. And so the release of these cell-free DNA fragments are non-random, and we can actually see patterns in where fragments map to. For example, are at specific loci, and then where there's chromatin, it is depleted, or open chromatin, it's depleted. So from nucleosome position, and this is really important because from other studies, for example, for nucleosome positioning, we know that these are not random and they're actually tissue specific. And from this information, we could theoretically, if we know where certain fragments or fragment lengths are able to map to, we can infer their tumor origin or tissue origin and hopefully associated to a certain tissue type. We can also look at other fragmentomic patterns, such as fragment length. For example, other studies have shown, and especially in the paper that, for example, Julia presented that on Lee Many from Derek Wong, a previous postdoc at the Pew Lab, that fragment lengths are shorter from patients that are cfDNAs derived from tumor tissue is shorter than the cell-free DNA derived from normal cells. So this is can give us can be used to infer the cancer status or even potentially other things. So, and then also we can look at fragment end motif, where, for example, these cell-free DNA fragments are cleaved at these nucleosome sites. Is there, for example, preference? Is there, for example, can we associate it to a specific tumor or tissue type? And all these things in combination can then lead us to inferring the cancer status. So here's just an example of the fragment length, this is a distribution of comparing cancer status or patients with that are cancer positive and versus healthy control fragment length. So you can see here, this dashed line is where this typical 167 base pair is, and you can the control is close to it. But you can see that the cancer positive samples have a distribution of the fragment lengths, and their frequencies are kind of shifted to the left. So more to shorter fragments are kind of derived from these cancer positive samples. So the fragment length can give us sort of this proxy of cancer status. So I'm not sure how I'm on time, but yeah, in general, so just giving an overview, I introduced two sequencing types, plasma whole genome and target sequencing, and this shift for plasma whole genome sequencing and its highly promising approach, especially from going from 1x to 30x, giving us that increased confidence. Then also what we can already do is variant calling from plasma samples, copy number alteration analysis, and then this future of fragmentomics. So a huge thank you to the Pew Lab for all their help, and then also BC Cancer. All these samples are from the CHARM Consortium, from their locations in Quebec, and then also the OICR team for sequencing these samples. And I do have other slides or fragmentomic analysis if there is time at the end, I'm happy to share that as well.
Great, thank you, Erik. We will have a lot of time for questions at the end. I see some already percolating. It's great. So I'm going to introduce Dr. Karen Gomez-Hernandez, who is a endocrinologist here in Toronto. And she has been our go-to for patients who have hereditary endocrine syndromes, such as multiple endocrine neoplasia, hereditary pheochromocytoma and paraganglioma. And she's going to talk about one of my favorite hereditary cancer syndromes known as von Hippel-Lindau disease. So I'm going to turn it over to my longtime friend, Karen. Go ahead, Karen.
Thanks so much, Raymond, and thank you for inviting me to this session. For the next few minutes, I will be using von Hippel-Lindau disease to illustrate a hereditary disease where targeted therapy has changed the treatment landscape. Certainly exciting times. So the identification of germline mutations that lead to hereditary endocrine tumors has allowed for the implementation of early genetic diagnosis and screening protocols in several conditions. For example, multiple endocrine neoplasia type 1, multiple endocrine neoplasia type 2, hereditary pheochromocytoma paraganglioma, neurofibromatosis type 1, von Hippel-Lindau, which I will refer to as VHL moving forward, Carney complex, and Li-Fraumeni syndrome. The recognition of many of the drivers of hereditary and sporadic endocrine tumors has opened the doors to new drug discoveries, such as the RET inhibitors for the treatment of RET-mutated sporadic solid cancers and hereditary medullary thyroid cancer, or hypoxia-inducible factor alpha inhibition in VHL, which we will elaborate on. What is VHL? VHL is an autosomal dominantly inherited disorder associated with high penetrance of benign and malignant neoplasms due to pathogenic mutations in the VHL tumor suppressor gene. And that's illustrated here on your top left corner. The most frequent tumors are central nervous system, CNS, hemangioblastomas, and retinal hemangioblastomas, followed by clear cell renal cell carcinoma, pheochromocytoma, pancreatic neuroendocrine tumors, and endolymphatic sac tumors. In addition, patients with VHL can have renal and pancreatic cysts, as well as epididymal or broad ligament cystadenomas. When patients are diagnosed with VHL, it is recommended that they're submitted to a surveillance protocol, and this has been alluded to in the first two presentations, to detect VHL-associated lesions. For example, as you can see in this table here, from the current surveillance guidelines, adult patients are recommended to have yearly eye examinations, yearly physical exams, and magnetic resonance imaging of the brain, spine, and abdomen every 2 years, amongst other screening tests that are done. But we submit these patients to these surveillance protocols, and when we do, we start, of course, detecting tumors. And at that point, a decision needs to be made as to whether to treat or offer active surveillance. And focusing here again specifically on VHL, before talking about targeted therapy, we're going to briefly review the general treatment principles of some of the tumors in VHL, but temporarily removing from the treatment strategy the use of the recently approved targeted agent, belzutifan. So as I just mentioned about a minute ago, central nervous system hemangioblastomas are very frequent in VHL. These tumors are the most frequent cause of morbidity and mortality, either to the tumor itself or actually its surgical treatment. Hemangioblastomas in VHL tend to be multiple, and the pattern of growth is commonly saltatory, so not predictable. So given this generally unpredictable growth pattern and the potential morbidity associated with surgery, in general, surgical resection is reserved for lesions that are symptomatic or those that are rapidly growing. Radiation can be used in certain scenarios, but usually small tumors are the ones that respond, and the cystic component of the tumor tends not to respond to the radiation treatment. Renal cell carcinomas, short RCC stands for renal cell carcinoma, also tend to be multiple and bilateral. But because the risk of metastases is low when these lesions are less than 3 centimeters, and I know these tumors are malignant, but the risk of metastases is very low when the lesions are less than 3 millimeters. active surveillance is generally recommended for small lesions. But if the tumor increases in size and is greater than 3 centimeters, nephron-sparing surgery has been considered the standard of care. Multiple tumors may have to be removed in a single surgery, and repeat surgeries are very common for these patients at intervals of every 3 to 5 years. Understandably, repeat surgeries can be associated with morbidity, including renal insufficiency, or of course have a negative psychological impact. Radiofrequency ablation has been used also to treat renal cell carcinoma, generally smaller tumors. In VHL, pancreatic neuroendocrine tumors tend to be slow growing and non-functional. Here too, the risk of metastases, just as we discussed with RCC, is associated with the size of the tumor lesion. And it is generally recommended that tumors that are greater than 3 centimeters, when located at the body or tail of the pancreas, are removed, and tumors greater than 2 centimeters located in the head of the pancreas should be considered for resection. But is it time to modify current treatment guidelines? And before we attempt to address that question, I want to first show you this slide, which illustrates the significant discoveries in the history of VHL, which, by the way, mirror the process of drug discovery in other hereditary cancers. First, in the early 1990s, Drs. Eugen von Hippel and Arvid Lindau identified the clinical features that would eventually lead to the coining of the term von Hippel-Lindau disease. Then fast forward to the 1980s and early 1990s, multiple investigators identified that sporadic renal cell carcinoma was characterized by an abnormality on the short arm of chromosome 3, which suggested that there was a tumor suppressor gene in that area. Then in 1993, the VHL gene was identified. In the 1990s and 2000s, the laboratories of Dr. Kaelin, Radcliffe, and Semenza, in their laboratories, it was discovered how cells sense and adapt to changing oxygen availability. For example, they discover HIV, hypoxia-inducible factor, and how the VHL protein interacts with it. In 2009, it was discovered that a small molecule could bind to HIF2, to the HIF2 transcription factor, and therefore it could potentially be targeted in a clinical setting. Then move to 2021, and belzutifan, a drug that targets HIV, was approved by the FDA for the treatment of VHL tumors based on the LightSpark study, as we will see shortly. Under normoxic conditions, HIF alpha is hydroxylated and recognized by the VHL protein, leading to proteasomal degradation. But in cells where there's a germline mutation in VHL and loss of the wild-type copy of VHL, even under normoxia, the VHL protein is no longer able to lead to the degradation of HIF alpha, which then accumulates and forms heterodimers with HIF1 beta, which then translocate to the nucleus, bind to hypoxia response elements, leading to the activations of genes that would normally counteract hypoxia by promoting vascularization. So, for example, VEGF, vascular endothelial growth factor, enhancing glucose utilization and increasing red blood cell production, erythropoietin. This, of course, would create a pro-tumorigenic, pro-neoplastic environment. So how does belzutifan work? Well, belzutifan is a small molecule that acts as a HIF2 alpha inhibitor. So what it does is it prevents the heterodimerization of HIF2 alpha and HIF1 beta, thereby inhibited this pro-neoplastic cascade. The LightSpark 004 open label phase 2 multi-center study, which is the one that eventually led to the FDA approval of belzutifan, recruited 61 patients with VHL older than 18 years with at least one measurable non-metastatic renal cell carcinoma, not requiring immediate surgery, and with no previous exposure to systemic therapy. So patients were treated with belzutifan 120 milligrams daily, and they were monitored for this response to therapy with CT scans, computed tomography, or magnetic resonance imaging every 3 months. The primary endpoint of the study was the percentage of patients who achieve response, and that's known as objective response rate, in renal cell carcinoma per the response evaluation criteria in solid tumors RECIST. The secondary endpoints included objective response rate in hemangioblastomas and pancreatic neuroendocrine tumors, but the study was not designed specifically to look at that. It's an RCC trial. Duration of response, time to response, and adverse effects. The median age in this study was 41 years. There was, as you can see there in the table, a similar percentage of men and women. 97% of the patients, again, illustrating that these patients do, in many instances, have to undergo a lot of procedures. 97% of patients had undergone some type of surgery or ablative procedure, with 66% of patients having undergone 4 or more surgical or ablative procedures. Most of the surgeries were for renal cell carcinoma and central nervous system hemangioblastomas. And 82% of patients had central nervous system hemangioblastomas, and 36% of patients had pancreatic neuroendocrine tumors. First, let's start with the renal cell carcinoma outcomes, which are shown here at 21.8 months and 37.8 months. Again, the 21.8 months results are the ones published in 2021, leading to the FDA approval of the medication. So the results at 21.8 months, an objective response was observed in 64% of patients at 37.8 months. No complete responses were seen at the time of the initial publication, but at 37.8 months, there was a complete response in 7% of cases. As noted in the table, there was a partial response in 57% of cases, and stable disease was seen in 34% of cases at 37.8 months. An important fact to mention is that tumors before the initiation of belzutifan were growing at a rate of about 3.6 millimeters per year. And with the initiation of belzutifan, they actually started shrinking about 3.7 millimeters per year. The median time to response was approximately 11 months, and the median duration of response had not been reached at 37.8 months. All patients experienced adverse effects, but most adverse effects were grade 1 or 2. And the grading refers to the severity of symptoms, with grade 1 or 2 being less severe, and grade 5 and grade 4 and 5 being very serious adverse effects. No patients experienced grade 4 or 5 adverse effects, but about 15% of patients experienced grade 3 adverse effects. Not surprisingly, the most common adverse effect was anemia, which is an on-target effect, as you might recall from a previous slide. There was also frequently seen fatigue and headache. In terms of the pancreatic outcomes, there were 22 patients with pancreatic neuroendocrine tumors. This is a small number of individuals, but this table, I think what is important to note here is that it is impressive that an objective response was achieved in 90% of patients after 37.8 months. Now, this central nervous system hemangioblastomas or hemangioblastomas. Hemangioblastomas were observed in 30%, so shrinkage of hemangioblastomas was observed in 30% of cases with stable disease in 62% of patients at 21.8 months. In addition, complete response was seen in 8% of cases at 38 months. And to summarize, one important, very important from a patient perspective, outcome here is that the shrinkage of the renal cell carcinomas, the hemangioblastomas, and the pancreatic neuroendocrine tumors resulted in a drastic decline in the number of procedures that patients required, quite drastic decline. So to finalize, at present, belzutifan is indicated for the treatment of adult patients with von Hippel-Lindau disease who require therapy for associated renal cell carcinoma, central nervous system hemangioblastoma, or pancreatic neuroendocrine tumors, and that's based on the study that we just reviewed. If the patients are not requiring immediate surgery. And this is certainly a huge advance in the treatment of this condition. But I think there still remain a lot of questions to be answered. So, for example, when to start therapy and for how long patients should remain on therapy. Thank you for your time.